Okay, we're going to discuss peripheral vascular disease and peripheral arterial disease. So peripheral vascular disease, form of atherosclerosis, is atherosclerosis is a primary factor for developing peripheral vascular disease. It's a progressive disease, may occur suddenly if an embolism occurs or when a blood clot rapidly develops in the blood vessel, or it could come on over time from atherosclerotic plaque that forms and then plaque rupture, like similar in coronary artery disease. So peripheral vascular disease is a general term that encompasses vascular insufficiency such as arteriosclerosis, arterial stenosis, Raynaud's phenomenon. Peripheral arteriosclerosis is common with the elderly and often associated with hypertension or hyperlipidemia. Peripheral vascular disease is frequently observed in patients with coronary artery disease, diabetes, and long-term smoking. So smoking is probably one of the biggest factors, threefold increase in development if you smoke. So what is peripheral arterial disease? As we know, narrowing of the peripheral arteries, most commonly the arteries of the pelvis and legs. Common sites: iliac artery, femoral artery, popliteal artery, tibial arterioles. Risk factors, again, smoking, hyperlipidemia, diabetes mellitus, hyperviscosity, often seen in conjunction with coronary artery disease, MI, AFib, TIA, stroke, renal disease. Other etiologies for developing peripheral vascular disease: phlebitis, surgery, autoimmune diseases. And how common is it? Affects about 1 in 20 people over the age of 50, or 8 million people in the US. Peripheral vascular disease is only diagnosed in about 50% of the population. Symptomatic peripheral vascular disease carries at least 30% risk of death within 5 years and almost a 50% within 10 years, primarily due to MI or stroke. So patients that are diagnosed with peripheral arterial disease should have a workup for general coronary artery disease and risk factors for stroke development. So the 5 P's of peripheral vascular disease: peripheral arterial disease, pulselessness, paralysis, paresthesia, pain, and pallor. Those are important to remember. Symptoms can be vague. A lot of times patients complain of intermittent claudication. The pain stops with rest. Numbness, tingling, weakness in the legs, burning, aching in the feet or toes. Sore in the foot or leg that won't heal, cold legs or feet, color change in the legs or feet, loss of hair in the legs. The other thing to mention is some of these symptoms can be confused with just symptoms, complications of diabetes, neuropathy. So they have similar, so sometimes the workup isn't complete because the provider assumes that this is just complications of diabetes that hasn't been managed well. Clinical presentation of the disease: so 50% of people asymptomatic don't even know they have it, 33% atypical leg pain, 15% of that classic intermittent claudication, pain when they walk, improves at rest. So intermittent claudication symptoms: exertional pain, 70%, stenosis, nocturnal pain, 70 to 90%, ischemic rest pain, 90%. So again, that nocturnal pain sometimes is something we don't necessarily ask about. We ask about, oh, do you have exertional, leg pain when you walk, but we forget to ask about when they sleep. Claudication versus pseudoclaudication. So pseudoclaudication, same plus tingling, numbness, burning. Exercise induced, it's variable. There's a lot of similarities, but the biggest thing is that it's time to relief is increased. So greater than, longer than 5 minutes, and it's more of a pseudoclaudication. So paralysis and paresthesia suggest limb-threatening ischemia and needs to be evaluated. when patients start having the 5Ps, when it looks like they have some life-threatening limb ischemia, it's best to get them to a limb salvage center. So a provider that specializes in limb salvage. Instead of waiting, sometimes when there's delay in getting a patient to a center, they then have issues with development of worsening ischemia and then amputation. So when we talk about pain scale, so subjective grading scale for pain and peripheral vascular disease. So grade 1, discomfort or pain, grade 2, moderate discomfort or pain, which the patient attention can be diverted from. Grade 3 is intense pain, which the patient cannot be attention diverted from. And then grade 4 is excruciating or unbearable pain. So just some key essential components of the vascular history. So we need to make sure that we talk about any exertional limitation of the lower extremities or muscles. So history of not being able to walk. Sometimes this is diagnosed. You'll get a patient that on discharge, they'll say, "Oh, I need a handicap placard because I can't get from, the car to the my house without having really bad leg pain." And it's not anything that's they're having any issue right now with their disease process. It's more that this maybe have been gone ongoing. So we need to make sure we ask about that. How far the patient can walk before symptoms develop. Are there any poor healing or non-healing wounds in the leg or feet? Any pain at rest localized to the lower leg or foot that when put upright or the recumbent position, does the pain go away? Physical exam. There's some physical exam findings we need to look for. And here's some fun pictures. So peripheral arterial disease. As nurses, we've all seen this. So the next couple slides are looking at the ABI. So the calculation for ankle brachial index is relatively simple and inexpensive to help us diagnose this lower extremity arterial occlusive disease. Patient needs to be supine for at least 10 minutes, measured at the highest systolic in both arms, use Doppler radial arteries. So this is basically how we go about using it. I'm not going to test you on the procedure or anything. I just think it's important you understand how it's ordered and how it's utilized. So once you get the measures, you get a index. So normal resting ABI is about 1 or 1.1. An index of 0.9 or less indicates the presence of obstructive disease. 0.5 or less suggests multi-level arterial disease, and an ABI of less than 0.26 indicates severe life-threatening limb arterial compromise. So again, this is, I'm not going to ask you how to calculate it, just understand that it is a calculation, but understand that less than 0.26 is resting ischemic pain, which needs urgent intervention. This is just a schematic example. So limitations of this in compressible arteries. Resting ABI may be insensitive for detecting mild aortic iliac occlusive disease, not designed to definite degree of function limitations. Normal resting values in asymptomatic patients may become abnormal after exercise. So again, it's an okay test. It's a good start. Then, if it is abnormal, that's going to be referred to a limb salvage specialist that could then do more advanced procedures. Duplex ultrasound with color flow imaging. This looks at blood flow and velocity of flow. It's used into localizing disease segments, and specific imaging can assess lesion severity. Then looking at MRI. So MRI is an angiography. So MRI is useful in evaluating arterial dissection and characterizing vessel wall morphology. It's looking at hematoma or thrombus. MRA has virtually replaced contrast radiograph for the diagnosis of PAD. So you get a really great arterial picture. You don't need to give contrast dye that can cause more renal insufficiency. 10% of patients can't utilize MRA because of their being claustrophobic, if they've had an implantable device that's not compatible, or obesity. So CT angiography does require contrast. So sometimes in renal patients that can't be utilized. These are some labs we should get. Again, pretty simple, basic electrolyte, CBC, EKG, looking for any underlying CAD. Treatment. So lower extremity PVD is treated initially by looking at risk factors and modifying them. So exercise training, medication, diet, stop smoking, interventional radiology, surgery, gene-based therapy. So exercise. So research has shown regular exercise is most consistent, effective treatment for peripheral vascular disease. Patients who partake in about 3 months are able to walk with less symptoms. So initially, they need to start off walking at a lower speed. Subsequent speed, you want to increase the walks greater than 10 minutes. Again, this is just for information. The guidelines. So again, we're going to get patients have chronic symptoms versus the acute 5 Ps. You want to make sure we get a good history and physical exam, diagnostic evaluation. Again, if life-threatening limb ischemia, then we definitely need consider getting them to a center where they specialize in this. And then, we want to utilize medications that have been evidence-based, and honestly, there's not a lot. We're looking at antiplatelets, aspirin therapy, Plavix therapy. No indication for Coumadin or our direct oral anticoagulants. Pladol is one of the drugs that is the mainstay. Statin therapy will help decrease the risk of plaque rupture. The no routine monitoring required for Pladol inhibits cellular phosphodiesterase, indicated in patients, contraindicated in patients with advanced heart failure. Surgical intervention, aortofemoral bypass, femoral popliteal bypass, or femoral crossover. Surgical interventions that can be utilized again for patients with severe disease, refractory to exercise and medical therapy. Other surgical interventions, angioplasty, stents, thrombotic therapy, thrombolytic therapy, stent grafts. So again, if you worked in a center with a physician or a team that is that looks at limb salvage, there's a lot of interventions that they do, including stenting and grafts. They do a lot of thrombolytic therapy if patients come in with an occlusion, to try and open that vessel up, and then look at, if they can't do that, trying to do bypass. Chronic venous insufficiency, we talked a little bit about, we'll talk a little bit more about it in DVT lecture. Basically, result of venous outflow disturbance in the limbs, restless legs, numbness, tingling, burning, swelling, shiny, taut, hyperpigmented skin. Diagnostic testing, venous duplex imaging to confirm diagnosis and assessment. Management, compression stockings, wound care. They could look at doing endovascular stent therapy, vein stripping. Aortic iliac occlusive disease typically involves the distal abdominal aorta as well as the common and internal iliac arteries. So aortic femoral bypass with prosthetic graft has been traditional treatment since the 1960s. Operative mortality and morbidity are 2% range, and long-term patency exceeds 90%. When I was a bedside nurse, I worked in a center that did quite a few of the aortic iliac bypass. Patients tended to do well. However, one of the biggest issues was to try and get them to quit smoking after their bypass. They still didn't want to do that. Aneurysm, so most common lethal peripheral vascular abnormality. Aortic aneurysms caused by weakening of the artery wall due to atherosclerosis, and the wall balloons out, forming an aneurysm. Screening for AAA predictors. So if you're white, a smoker, have a history of atherosclerosis, if you've had aneurysms in the femoral popliteal arteries, obesity, if you've had a first degree relative that had it, you need to be screened for it. Abdominal AAA defined as the diameter at least 1.5 greater than the diameter of the level of the renal arteries, usually diagnosed when the diameter is about 3 centimeters. 4 to 6 times more common in males and developed 10 years later in females on average. So the older you get, the more prevalent it is in female. Subclavian stenosis. This just talks a little bit about patients develop neurosymptoms as a consequence of brain ischemia in severe cases. Subclavian steal syndrome, less common than lower extremity peripheral arterial disease. Left subclavian arteries, the most common. Again, the risk factors are the same. So hypertension, smoking, non-modifiable risk factors, family history, age, and if you're male. Muscle cramping from the ischemia in the arms, especially if you lift them over your head, they get dizziness, vertigo, visual disturbances. Different blood pressure, systolic blood pressure differs brachially. Anginal symptoms following if they've had bypass, lima to the LAD. This is just a picture of subclavian steal syndrome. And then after procedure. And that's all on peripheral vascular and arterial disease.